This is wonderful. Marc presented at our kickoff meeting, as well as offering to present today. I've had the honor of working alongside Marc on various NIH-funded studies over the past decade. It's just an honor and a privilege. In addition to his work leading our the clinical trial, the clinical team portion of our J-Coin randomized trial. So Dr. Fishman is a board certified addiction psychiatry and in addiction medicine. He's a member of the psychiatry faculty at Johns Hopkins University School of Medicine and medical director of Maryland Treatment Centers. He's also affiliated with Friends Research Institute. Dr. Fishman leads Maryland Treatment Centers, a regional behavioral health care provider, which includes Mountain Manor Treatment Center in Baltimore for adolescents, Mountain Manor Treatment Center in Emmitsburg for adults, as well as several other inpatient and outpatient programs. In that role, he's been involved in development and implementation of innovative programming in addiction and co-occurring disorder treatment. I know this firsthand. He is a very creative thinker, and he identifies problems because there's lots of them and tries to figure out ways to make it work. So he's really great at thinking outside of the box. His clinical specialties include treatment of drug-involved and dual diagnosis adolescents, opioid dependence in adolescents and adults, and addiction with comorbid pain. His research work is focused on models of care and treatment outcomes in adolescent addictions, in particular opioid dependence. So Dr. Fishman will be speaking today on treating co-occurring opioid use disorders and other mental illness.
Great. Well, thank you, Shannon. That's terrific. And so I'm going to be talking about co-occurring disorders. You guys all know that this is a major issue and a vexing issue and a problem for our patients who suffer with distress of both kinds of conditions, and a problem for us in our system in trying to address it effectively, which is difficult, but when we get it right, so satisfying and so effective. This is, I'm going to talk a little bit about problem. I'm going to talk a little bit about clinical approaches. I'm going to nerd out with you a little bit on a little bit of data, and then maybe show you some cases. But I hope to spend at least half or a third of the time in discussion and as Shannon said, taking some questions. I'm sure you've got things that are on your mind that you want to ask about. Obviously, we only have time for an overview, but as Shannon said, it's a start, not a finish, and a beginning of a conversation that I hope that we can continue over the course of this project and the future as we work together, continue the collaborative. So here's a summary of some of the major points. Co-occurring psychiatric symptoms and disorders are common in SUD. That's no surprise to you. And it's a two-way street of reciprocal exacerbation. One set of disorders makes the other worse in both directions. It's difficult to do these diagnoses, differentiating what are transient symptoms versus what are persistent disorders that need independent treatment is inexact and benefits from longitudinal monitoring. What does that mean? It means getting to know the patients, which is what we want to do when we treat people in generally. The good news is that psychiatric medication treatment is largely safe and effective in the context of SUDs, even when people are persistently using. That's good news. And that includes the use of MOUD when the SUD happens to be OUD. So in combination with the FDA-approved OUD medicines, buprenorphine, naltrexone, methadone, most of our psychiatric tool chest is still good. When we can integrate the treatment, that's best. We don't always get our aspirational goal given system and other barriers, but that's best. And then, of course, there's special circumstances that have to do with particular substances. Is it cocaine? Is it fentanyl? With particular conditions? Is it bipolar disorder? Is it depression? Is it schizophrenia? And different kinds of treatment modalities. We won't have too much time to get into those weeds, although if there are issues there on your mind, happy to talk about them in questions. So this is a kind of a quick look at the lifespan, looking at the prevalence of substance use for tobacco, cannabis, and alcohol. You already know, just considering SUD, right, that this is a developmental disorder of pediatric onset in which people acquire the problems, initiate the use in the second decade of life, and then use and problems peak at the end of the second decade of life, beginning of the third decade of life. Well, it's also the case that psychiatric disorders have that kind of concurrent onset. A half of psychiatric disorders have onset before age 15, and 3/4 of psychiatric disorders have onset before age 24. So it's no wonder that co-occurrence is the rule rather than the exception. Looking at the scope of the problem, I'll illustrate this first in adolescence and then show you similar data for adults. This is one particular disorder, major depression, MDE, major depressive episode. And the notion here is that major depression goes along with initiation of substances in young people. So you see here rates of initiation of alcohol on the left, illicit drugs on the right, in relationship to whether or not these individuals had an episode of major depression in the past year. And you can see for alcohol, it's double the risk. For drugs, it's triple the risk. They go together. Now, I can't tell you which came first, chicken or the egg. This data doesn't tell you that, but it does tell you that they go together. And the same is true for adults. So here's over 18. This is incidence of drug dependence. I mean, we can slice it and dice it a number of ways. Drug dependence, not including cannabis, alcohol dependence, alcohol or drug dependence. And again, based on whether there was past year major depression, and you can see there is considerable increase in risk. And again, it's reciprocal risk. You're more in trouble for depression if you have substance problems. You're more in trouble for substance problems if you have depression. It's a double whammy. And just to get a sense of what the prevalence rates are, right? Look at the far right, and you can see that somewhere in the 15 or 20% range of co-occurrence, right? If we're talking about depression. That doesn't consider other diagnoses, PTSD, schizophrenia, psychotic disorders, anxiety disorders. Trying to get a handle on what exactly is the co-occurrence prevalence is a sticky wicket, as we'll talk about when we talk about assessment, diagnosis, and formulation, but it's high. And the estimates are somewhere in the range of 40 to 80%, and that's in population prevalence. That's a pretty broad range, right? You can drive a truck through that, and that speaks to the inexactitude of our diagnostic ability and the inexactitude of looking at things cross-sectionally. Remember what I said, that it takes longitudinal getting to know a person to know what the real deal is. The other thing that might surprise you about the lower end of that estimate of prevalence is that, remember, that's a population estimate, not a treatment setting estimate. When people present for treatment at the clinic, in carceral settings, in the justice system, that concentrates morbidity, including comorbidity. So when people show up to us, if I were to ask you, what do you think the rate of co-occurrence of simultaneous psychiatric problems and substance use disorder problems, most people, including myself, would say everybody. It's 100%. And if it's not 100%, it's 99%. And that's because we tend to see the most severe cases concentrated in our treatment presenting or service presenting or criminal justice presenting settings. So it's no surprise that that's what it looks like to us. Here's a view of how co-occurring disorders to outcome. This is data that we collected among adolescents at Mountain Manor, these many moons ago, but it's the same kind of thing that pertains to adults. This is looking at young people coming into an index episode of acute short-term inpatient treatment for use. You can see that they are of very high severity, using almost every day. That's the severity axis. What's the percentage of substance using days in the past 90 days? That's how you get into residential treatment, right? You're a high severity. So using almost every day, but then it differentiates them by whether they have high or low depression scores. BDI is the Beck Depression Inventory, one particular measure of depression. And you can see that this is somewhat longitudinal follow-up data. They come in using lots and lots and lots of substances on most days. They have a month's worth of inpatient treatment. They get discharged to the community and out at 3 months. There's been a substantial reduction in the amount of substance use, not to zero, right? We don't have the cure, but a considerable reduction. And then over time, back out in the community, they're not attending follow-up care. They're back in their home communities with using peers. And there's the typical checkmark pattern of lapse and relapse. Although even at 12 months, although they're worsened and some of them have relapsed, there's still considerable improvement from original high severity admission. But the main point here is the distinction between those in blue with higher depression versus those in red with lower depression. And those that have depression tend to do worse, don't get as well, relapse more. So the lesson there is we ought to pay attention to that and try to do something about it. So how do we do that? Hopefully we can do better than Gary Larson says, right? Here's me talking to somebody with co-occurring disorder and my diagnosis is just plain nuts. That won't do. So how do we get better than that? Well, it's problematic, but remember, as I said, there's a very high prevalence of comorbidity, and that includes both conditions that preceded substance use. That is, there are people who have psychiatric symptoms and disorders from early in their lives, long before exposure to substances. There are people who, as a direct effect of exposure to substances, have toxic effects of the poisons they ingest and have drug-induced symptoms. But often we can't distinguish between number 1 and number 2, and we end up with number 3, which is drug-exacerbated conditions, in which maybe it was before, maybe it was after, and probably it's both. And by the way, full diagnosis implying people have 2 problems. The severity of most of the people we serve, when was the last time you saw a troubled patient with only 2 problems, right? It's 6 problems, it's 7 problems. And that makes it even more complex. Here's a question we've been talking about. Is it chicken? Is it egg? And as I said, sometimes you can tell the difference. This is a person who at age 6 had trouble with mood regulation. By age 10, had developed a clear major depressive episode, and then started substances at age 14, 15, right? Sometimes it's explicit the other way. Here's a patient who, or a person who was smooth sailing, meeting milestones within the range of relative normal without psychiatric disorders, started using, developed a substance use disorder in their teenage years, and then developed mood symptoms or psychotic symptoms, not before. But as I said, those clearer cut cases tend to be the minority. The majority is, it's a bit of a jumble. You talk to the parents, when did this person first get trouble with their moods, with other psychiatric symptoms? Oh, I don't know, 13, 14. When did they start using drugs? Oh, I don't know, 13, 14. And so it's all a jumble, and that's what we have to live with. So what can we do with that? Well, one thing is we might say, it's not that big of an issue. We'll just deal with it and pursue concurrent integrated treatment. And I'll talk more about that later, but that's mostly our approach. But there are some things that we can try to do to help sort it out. As I say, mostly we have trouble sorting it out, but when we can sort it out, it can be useful. And the things that in the history and the examination that can help us see persistence of a psychiatric disorder as opposed to transient psychiatric symptoms exclusively related to drug use and a drug-induced state are things like are listed here. Does psychiatric disorder run in the family? Were there symptoms, as I mentioned, of psychiatric disorder prior to initiation of substance use? Were there persistent symptoms during episodes of abstinence or reduced substance use? Now, there are people who've never had abstinence and have never cut down, but there are people who have. Did you spend the summer at your grandmother's in South Carolina and weren't using that summer? Were you locked up for a time and weren't using? Did symptoms persist? Are there previous psychiatric evaluations that suggest a longitudinal persistence? Was there a response to previous treatments that suggests a response and the likelihood of a persistent disorder, especially response to medication? And then the higher the severity and persistence and dangerousness of the psychiatric symptoms, the more likely we are to see urgency in the need to address them rather than waiting to see if they resolve. And that's the fundamental issue in assessment and formulation, right? Do we see this person with substance use disorder and psychiatric symptoms in a formulation in which we think if we can get the substance use disorder under control, these symptoms are most likely substance induced and will most likely considerably improve or even resolve seriously without additional psychiatric treatment, without additional psychiatric medicines, which confers risk, right? All medicines have side effects. So that's one approach. Is that the approach we want to take? And with OUD in particular, we have this great tool of MOUD, of medications, which sometimes can help us stabilize the SUD quickly. So would we want to wait to see the response to MOUD before we jump in with antidepressants, mood stabilizers, antipsychotics, etc.? Versus, do we want to formulate this person as having independent co-occurring disorders with a persistent psychiatric disorder that needs concurrent treatment with a regimen of psychiatric treatment in addition to the regimen of SUD treatment, whether that's MOUD or counseling or both or other things? And there is no gold standard. There is no blood test. There is no CAT scan. There's no dog scan either. But the idea that we have no ability to know for sure. So you have to chance. You have to use your best judgment. It's hard to do cross-sectionally. Your best way to do it, as I've mentioned a couple of times, is monitoring over time, getting to know patients as you see things unfold. But that's often not a luxury you have cross-sectionally when you have to make a decision, treat or don't treat. So pros and cons. If you wait for spontaneous resolution, you will have better diagnostic precision. You will have less side effects because you've prescribed perhaps fewer medicines that were perhaps unnecessary. But the trade-off is you'll have less opportunity for early and effective because you've not treated the presumptive co-occurring disorder that you formulated isn't real. On the other hand, you can move ahead with a presumptive diagnosis and a presumptive treatment, and you'll have less diagnostic precision. You'll be wrong some of the time. You'll have been over-aggressive sometimes and needlessly prescribed medicines that could have side effects, but upside, you'll have better opportunity and more effective treatment. Which approach is right? Yes. The notion is that everybody has a particular bias. I happen to be more treatment forward in my approach. Part of that is because I'm a therapeutic optimist and I think treatment works, but it's also because the patients I see are very high severity. They've already had lots of opportunities to have no treatment. So they're not seeing me first, they're seeing me 27th. So by that time, I'm probably more convinced that something needs to be done rather than waiting. But again, I just want to introduce this as an explicit weakness in our technology, and to know that part of a practice approach and a system approach is to both take a stance here, pros and cons on either side, prepare that sometimes you will be right, but sometimes you will be wrong, and be humble about it. You can have a hypothesis and reassess that hypothesis and either hold the course or change the course, but be flexible and be thoughtful. So what kind of treatment do we do? Well, we no longer do psychoanalysis of patients with co-occurring disorder as depicted in this cartoon. And it's important to remember that one of the reasons we do this kind of treatment is to prevent relapse, because one of the most common causes of psychiatric relapse is substance use, and one of the most common causes of substance relapse are psychiatric symptoms. So it matters a lot in both directions reciprocally. So we use the full tool chest of psychiatric treatments, and that includes medicines and that includes psychotherapy. The whole standard tool chest, fortunately, is relatively safe, relatively effective. That's luck. Methadone does present some complications. It's a little tricky in terms of drug-drug interactions with some of the psychiatric medicines. But other than a few methadone interactions, our psychiatric medicines are relatively safe despite MOUD, naltrexone, methadone, buprenorphine, and despite ongoing active substance use. We don't have to say because you're still using cannabis, cocaine, alcohol, fentanyl, that therefore my hands are tied and I cannot psychiatric treatment. Didn't have to be that way, right? There are plenty of drug-drug interactions and substance drug interactions that are unsafe. We happen to be lucky with the tool chest of psychiatric medicines that it has worked out. So abstinence is not a prerequisite. They won't work as well if a person is still using, but they will not work at all. That's a double negative. They will still work somewhat. And the idea is abstinence is not a prerequisite, but clearly you want to be explicit that the target is decreasing use and decreasing over time towards the gold standard of abstinence. But it has to be a longitudinal view. It has to be long-term engagement. To expect that at first prescription of treatment, whether that's MOUD or psychiatric medicines, all things are fixed and we have a cure as if this were an infectious disease, say community-acquired pneumonia that responds to 7 days of penicillin, and then we're all done. It's not going to be like that. It's going to be 3 steps forward and 2 steps back, sometimes 1 step forward and 4 steps back, and that has to be an explicit part of the expectation. Engagement includes what it takes to build therapeutic alliance, both to an individual practitioner and to the system. And to the extent that we can involve family as helpers, that's a big plus. I'm a big fan of that. We don't have time to talk about family strategies, but it's super important. And again, that we expect incremental remitting relapsing course, not sudden cure in a unilaterally successful every time way. And don't hold your breath waiting for insight. Hopefully that can come, but it doesn't tend to come early. And with both SUD and psychiatric disorders, non-adherence to treatment is the rule rather than the exception. Just because we give good advice doesn't mean that advice is digestible. Doesn't mean that the patients will go, oh, okay, I'll do exactly what you say and take all my pills and all will be well. We all know it doesn't go like that. And nobody wants to be a sick person, wants to have the label of or mental illness. I'm sorry, that's the hand God dealt you. Thank goodness we live in an era where we have these miraculous tools that I can help you take the benefit of, but I can't pretend that you don't have these problems. But that is certainly, whether you want to call that self-stigma, and we're going to have a talk about that later in the day, but it's a difficult situation for patients to come to terms with, and non-adherence is common, you know that. Now, psychiatric medicines are a miracle, but compared to many other subspecialties of medical treatment, they have a bunch of limitations. Part of the problem is that they have poor specificity. You know, with infectious diseases, I can look under the microscope and see what bacteria is in your lung causing your pneumonia, and I know that for that bug, a drug, and it's a perfect match in terms of what is going to kill that bug dead. We don't have that specificity in psychiatric treatment. They are unfortunately usually slow acting. For patients in distress, that stinks. Doctor, I'm suicidal today. Okay, well, I have a medicine that might help you be less suicidal 6 weeks from now. But that's what we have. We have no laboratory verification of diagnosis, treatment matching, or treatment response. We don't have the technology that our colleagues say in oncological medicine or infectious diseases have. Often it takes more than one trial. I don't always get it right the first time. That's very burdensome to patients. Doc, This doesn't do anything for me. Let's try something else. Okay. Oh, that didn't work. Let's try something else. Okay. That caused side effects. Doc, you're treating me like a guinea pig. That's a very common feeling for patients. It's understandably frustrating. It's a barrier to treatment adherence and success, but it's what we got. So it's important to do role induction, to ask people, to remind people that they have to hang in there, that it's worth doing, that there's a light at the end of the tunnel, that it's a process. That's difficult. And by the way, our SUD patients are not exactly future-oriented, slow-acting, contemplative folks, right? They tend to be, I want what I want when I want it kind of folks. It's hard. These treatments require long courses and intensive monitoring, but the good news is they are effective over time, but it's hard to be patient. They can also have side effects. Here's an old ad from a treatment we don't really use anymore, tapeworms for obesity. You can imagine that had side effects, and our medicines are notorious for having side effects, whether it makes me stiff, it makes me dull and flat, it causes me to gain weight, it brings problem to my sex life, it makes me sleepy, on and on, it upsets my tummy, it gives me headaches, and on and on. You know the drill. Those are real, those are barriers, they need to be addressed, and part of being good at treatment is being sensitive to patients' concerns about side effects, talking to them about it even when they're embarrassed to talk about it. For example, talking about sexual side effects is hard for patients. And being willing to try new things and be flexible and encourage them that just because you had side effects with one, I got 27 other cousins of that medicine. Hang in there with me. We'll find something. But as I said, that's hard. Which is better, medications or psychotherapy and counseling or meetings? The answer is yes. All are important components of treatment, integrating them together, although difficult to do, and although asking a lot of patience, is better. Here is one of my favorite co-occurring disorder treatment studies. It happens to be an adolescent study. The principles still apply to adults, but Paula Riggs at the University of Colorado, who's really a pioneer in co-occurring disorder treatment research, had a very nice design here, and it's one of the nicest examples of documentation of how we see that the psychiatric disorder and the SUD response tends to go hand in hand. So real quick, pardon me for nerding out here, but real quick, the idea is that this was a trial of the antidepressant fluoxetine, that's the brand name Prozac, plus psychotherapy for adults with major depression and SUD. So half of them got active fluoxetine plus the psychotherapy, half of them got placebo, sugar pill fluoxetine plus the psychotherapy. And the initial questions were, one, is antidepressant safe and effective in patients with major depression who are actively using? Because that's important to know. First of all, is it safe? You don't want to do it if it's not safe. And does it still work? And then the second question was, and what happens to the substance use if you treat their depression? So question number one, this, I haven't gotten to the data on this slide yet. I'm giving you the background. Question number one, is it safe? Yes, it was not a problem. Despite ongoing use of substances, patients did not have problems of the medicine. I mean, medicines have side effects, had the typical kind of side effect, rare side effects of fluoxetine, but there were no worse side effects or no big safety problems because they were actively using. So was it effective? Yes. It turned out that although patients in both groups, placebo plus psychotherapy and active medicine plus psychotherapy, did get better and did respond to treatment, it was statistically significantly better in the antidepressant group. Now, why did people in the placebo group get better? Well, there is such a thing as a placebo response. But secondly, psychotherapy is an effective treatment for major depression. So although psychotherapy helped, more of them got better if they took the active medicine. So yes, safe and effective for major depression despite ongoing substance use and having substance use disorder. What about the substance use. If there was a greater response to fluoxetine for depression, was there a greater response to fluoxetine for substance use? Unfortunately, no. People would like to think that if only we could treat the underlying psychiatric disorder, the substance use will melt away, right? So give them the pill for the depression, their depression gets better, or by analogy, the pill for PTSD, the pill for anxiety, the pill for psychosis, whatever, and substance use will go away because after all, they're only self-medicating. I'm not saying that self-medication is not a real thing, but as it turns out, that's not so. It doesn't melt away because of the medicine. But people in both groups did get better from both their depression and their substance use. Some in the fluoxetine group, some in the placebo group. Both were getting psychotherapy, both for depression and substance use. But now come to the data at hand. If you divide the patients not into which treatment they got, but to whether or not they were a depression responder. So the blue folks are the patients, the participants in the study whose depression did eventually get better. The red folks are those whose depression did not get better. And lo and behold, the blue folks whose depression got better are the folks whose substance use got better. And the red folks whose depression did not get better are the folks whose substance use did not get better. So whether the depression responded to medicine, psychotherapy, or both, that's where depression also, where substance use also responded. So they tend to go together. Again, this does not address the chicken or egg question. Did substance use get better because depression got better? Did depression get better because substance use got better? I think the answer is that that's the wrong question. That's oversimplistic. They get better together in integrated treatment. And so this is a nice reflection of the paradigm of integrated treatment in which to expect that one set of disorders will get better without the other getting better or being addressed is to set ourselves up for failure. But if we can work with both disorders simultaneously, where we achieve success is where both respond, whatever it takes, medicine, psychotherapy, meetings, all of the above. So again, big fan of this study, and I'm still waiting for people to do similar well-designed work like this in adults, and there hasn't been enough work, but it's a similar principle, and what research work we have in adults supports this same kind of notion. A minute, just to talk about, since this particular collaborative is about OUD, I want to talk about opioids and depression, and show you just a little bit of data. For sure, depressive symptoms are very common in the acute presentation of the unstable person with active opioid use. We see tons of patients, tons of people, whether in criminal justice settings or otherwise, who are using, whose lives are chaotic, whose life circumstances and whose mood regulation is very much perturbed, who have symptoms of depression, whether that's sad mood or anxious mood or irritable mood or angry mood or labile mood or all of the above. And as we've been talking about, it's very hard to know, are these folks who, if only we could get their opioid use stabilized, would resolve, or do they need antidepressant treatment? Well, as it turns out, the emerging consensus is that most of these depressive symptoms to improve if the OUD stabilizes on MOUD. OUD has the advantage compared to other SUDs that we have high effect size, very effective medicines that can give us quick stabilization. We don't have that for cocaine. We don't have that for alcohol. We don't have that. But with the MOUDs, methadone, buprenorphine, naltrexone, we can, with relatively rapid course, not in all the patients, but in a subset of patients, see a relatively dramatic stabilization of the OUD. And in that case, most of the depression resolves, but not all of it. And we can't tell the difference prospectively about who's the most and who's the but not all. So we did some secondary analysis from a famous OUD trial called XBOT, which was a randomized trial of extended release naltrexone versus sublingual buprenorphine. And we saw that baseline depression was common, not surprising to you guys who see these individuals. 14% of the 400 and some patients in the trial had moderate or severe depression, and 35% of them had mild. So by combination, 49%, almost half of them, had some substantial depressive symptoms. Did they have a depressive disorder? I don't know. Well, the trial put them all on MOUD, or most of them got onto MOUD. They were all, some of them didn't. Most of them did. And by 4 weeks of MOUD, most of the depression was better, that either it responded or remitted. 76% of those with mild depression, that was 35% of the group, either responded or remitted with lower or zero depressive scores, and 53% of those with moderate or severe depression responded or remitted. Now, 53% is a lot, but it ain't all of them. So half of them still had depression of a moderate or severe level. Now, granted, that was only 14% of the group, and that's half of 14%. So it's not the majority, but it's nevertheless a significant minority. And we couldn't identify at week 0 who those were going to be. And those people that did not respond, although it didn't reach statistical significance, it almost did, they had greater risk of relapse. So it matters. You tell up front, and since you can't tell up front, what should you do about it? This particular trial, antidepressants weren't part of the recipe. It was an MOUD trial. But in real life, I or you or any of us would be confronted with the puzzle, should I add antidepressants to the sauce? Here's another bit of work we did with the same group of patients. This is not just who reached a certain threshold at 0 and 4 of depressive symptoms. This is the Hamilton Depression Score, just another measurement of depressive symptoms. This looks at dividing them up into 3 groups of their longitudinal course over the 6 months of the trial by what happened to the progression of their scores. It tells a similar overlapping story, but it's instructive. 85%, the bottom kind of greenish group, had relatively low scores at the outset, and they stayed low with MOUD. But these other 2 groups, again, the minority, 15%, 5% in the top red and 10% in that middle blue, had higher scores that either got better and then got worse or stayed high. We couldn't tell at week 0 who these were going to be. But again, this 15%, and especially the percent in red, had higher rates of relapse, stopped their medicine, got in trouble. In retrospect, I wish we'd given them all antidepressants. I just didn't know who they were. So that again comes back to reflect this puzzle we have, and you've got to make a decision. Am I going to, for the 15%, be perhaps over assertive about treatment, and then unfortunately catch some of the 85% who didn't need the medicine, or vice versa? Now, fortunately, I don't have to base my decision just on one silly score on a computerized test, right? I get to meet people and get to know them and understand about their family histories and all the other list of things, and get to make a hypothesis and model over time. But that's the standard of care. And anybody who imagines that there is some simple recipe that can be algorithmicized, if that's a word, to just say, what's your score? And that will get you medicine, and that will get you good outcomes, and that will get you cure, is fooling themselves. I want to just talk for a second about engagement. You guys know about that. So much of treatment is getting people to show up, meeting them where they are, forming therapeutic alliance, working with relationship, and being optimistic. Therapeutic optimism is still one of our best tools. Even if I can't cure you, I want to encourage you that this is worth doing. I want to encourage you that there is light at the end of the tunnel. I want to encourage you that everybody can get better, that nobody is hopeless, and that I'll never give up on you. Despite my pitch for integrated co-occurring treatment, it doesn't happen nearly as often as it should. This is old data, but it hasn't changed much. Very few people get integrated treatment. Half the people get no treatment. It's a shame. As my grandmother says, what happens shouldn't happen. But anyway, and the system is hard to navigate. I like this cartoon of the many-headed traffic light. If you think it's complicated for us, as I hope I've convinced you, imagine being a patient or an individual in the criminal justice system with co-occurring disorders in crisis. Where do you turn to? Where do you get this kind of help? Whose advice do you follow? You may not have choices anyway, but it's difficult. How are we doing for time? I should stop. I've got some cases here, but I want to have some discussion. So let me stop and see if there are questions. Either people unmute themselves or in the chat. And Shannon, if you want to help moderate.
Yeah, thank you so much, Mark. That was fantastic. A little daunting, to lay it out like that, but really informative.
Again, a Gary Larson cartoon. Treatment works, recovery happens. Bobo remained free the rest of his life, although he did find it necessary to seek help. Right? That's our co-occurring patient.
One of the things that jumped out at me, just to sort of launch it, is you talked about, to some of the folks on the call might actually sound like a luxury. Like when folks come into Mountain Manor, for example, residential, they're going to be there for a few weeks. You have a chance to really get to know them. You have a fairly comprehensive therapeutic team that can work with them to help disentangle some of these chicken, egg, all of the above kinds of things. When people come into a jail, there's sometimes a very short window. And usually you don't know exactly how long that window is going to stay open.
Yeah.
And I wondered if you could maybe speak to, well, you mentioned therapeutic optimism. I didn't know if there were other key things that you thought would be helpful in terms of indicators for launching someone both on an MOUD, which is what HB 116 is talking about, but you also mentioned not everybody is going to totally get better if they have a co-occurring disorder if you just treat the opioid use. So trying to figure out, like, other than therapeutic optimism, what kind of messages or questions do you think are most important to ask to help disentangle some of these co-occurring disorder issues to figure out where to go with treatment during what is not likely to be a long period of time?
Yeah, no, that's a great question that it's together all the both individual and system issues. I think number one is anybody with OUD ought to be started on MOUD. That is at this point, after 60 or 70 years of studying this problem, that patients who don't get MOUD, even if they aren't using today because they're in confinement, they're abstinent artificially by confinement, they're locked up or in a rehab or whatever it is, they have an enormous rate of relapse without MOUD. And when they lose tolerance by abstinence by confinement, they are at enormous risk when they are discharged either from rehab or from carceral settings. And that relapse confers at least a 10-fold increase beyond baseline of OD. So the first 30 days after release is an enormously risky time, and that is addressed by starting them on MOUD. And even if adhere longevity, stick with it. Of course, we'd like that. The longer they stay on, the better they do. Even being on MOUD active temporarily can be life-saving. So that's number one. MOUD first, MOUD forward. Doesn't matter if it's methadone, naltrexone, or buprenorphine, but one of the three. Then when they also have psychiatric symptoms, to the extent that a carceral setting provides a longitudinal view, that's a luxury. That's great. We don't know how long they'll stay, but the longer we get to know them, the better we can do. And then linking whatever decision we make about treatment or withholding or postponing treatment, I shouldn't say withholding, about postponing treatment, try to link that to a next step plan. And all of us do that in carceral settings as best we can, obviously with resource constraints, but as best we can in terms of linking people to community resources so that on community reintegration, we offer them an opportunity to try to link to other care to continue whatever work we start. Mm-hmm. And whether that's continued monitoring of response to the medicine we start, or it's monitoring to the symptoms for which we didn't start a medicine, but we want to see is one needed. In either case, it's going longitudinal monitoring. Now, of course, patients won't always do that. Don't get me started about the lack of Medicaid benefits in carceral settings. That's another political conversation for another day. Hopefully, Congress will wake up and smell the coffee, but that's beyond today's rant. And the notion that it doesn't stop with whatever we do. But in thinking about what we ought to do, it's back to that list of getting to know the patient and thinking about the other factors that make it more likely that this is a person who deserves a trial of medication treatment. And that has to do in part with knowledge about past treatment and past treatment response. Person says, this is the treatment that helped me, and that seems credible. That's super useful information. Obviously, we don't want to do something safe. Yeah, what really helped me with my home doctor was 200 Xanax a day. Can I please have that? And I'd like to smoke it if you don't mind. I'm going to do that. But for the most part, if a person has a credible story about a good treatment response to sophisticated and reasonable treatments, that's probably worth repeating. And the more severe and urgent the symptoms are, the more we are pushed to want to do something quickly and be willing to err on the side of over-aggressive treatment because it's urgent, because it's important, because the person is clearly suffering and in distress.
We have a question from Daniel. Do you want to unmute yourself, Daniel, and ask it?
Yes, thanks, Shannon. Yes, Dr. Fishman, one question I had, thanks for the presentation, but was just wondering what are some strategies you would suggest that could be utilized for engaging those criminal justice involved individuals while they're in jail to, one, be aware of the MOUD treatment and certainly at least consider those treatment options?
That's a great question. I think the first step is that as more and more carceral settings make this treatment available as part of the standard range treatments available in medical services, people will hear about them, will be informed about them. So first they've got to be available. People have got to be familiar that they exist. There's got to be capacity in the system. Bill 116 is going to gradually make that more prevalent. We've got problems with implementation. We've got problems with an unfunded mandate, et cetera, but we hopefully will get there. That's number one. The second thing is doing screening and education. There will be many individuals, many staff members who have misperceptions about the role of MOUD. You guys have heard it all. It's trading one addiction for another. It's not real recovery, and a crutch, on and on. And so we have to counter message that and educate people the real value of a real medical treatment with known effectiveness and help people understand. And if they don't say yes right away, we keep working with them and we keep educating them. And we try to do our best to try to have a menu of options so that we're not in a one-size situation, but can give people options, learn right before, maybe try something different this time. But again, it's building a robust system that has response from screening to assessment to treatment to treatment response and changing as needed.
Well,
that makes sense? Yeah, great.
Thank you so much, Dr. Fishman. We're at time. I'm sure that, you know, if we were all in a room together, this would really generate a lot of great discussion. Again, for everyone who's on today's Zoom meeting, if this stimulates other questions, we will, you know, there are ways that you can directly access Dr. Fishman. There are other resources we will make available. And, you know, these are really complex. Obviously, these are some of the most complex patients, and they're trying to be treated in the midst of, you know, a detention episode. And there are just so many other extraneous factors that can really compound how hard these folks can be to treat. And so doing what you can with what you have during the time that you have them seems so critically important. But thank you so much, Marc, for sharing that today. And we will post both your video and other resources associated with the topic of co-occurring behavioral health disorders with opioid use disorder on our website. Right.
Great. Thank you, everyone.
Thank you.